An article published this week in AJR reports one center's 20-year experience from running a CT colonography program that has focused on the use of CTC for primary screening. The study summarizes results from over 15,000 CTC exams, including over 9,000 screening exams. I'm Andy Rosenkrantz, editor-in-chief of AJR, and I'm here today to discuss the article with its lead author, Dr. Perry Pickhardt, professor of radiology at the University of Wisconsin School of Medicine and Public Health. To start us off, can you describe your institution's CTC program?
Sure. So as a kind of a quick background, I arrived at UW in December 2003 after about a 3-year stint at National Naval Medical Center in Bethesda. And it was that same month that our multi-center DoD Army-Navy screening trial was published in the New England Journal of Medicine, which actually showed for the first time that CTC was actually a very good screening test, as good, maybe even better than the optical colonoscopy reference standard for detecting advanced neoplasia, which is really crucial for prevention and detection. So anyway, with that paper in hand, I was able to convince our local third-party payers, HMOs, PPOs, and the like, to start covering CTC screening. And so as of April 2004, our program officially got its start with commercial coverage. And from the beginning, we set this up as a dedicated screening program that engaged our primary care providers and gastroenterologists. We had a program coordinator from day one and also offered same-day polypectomy for significant polyps that were detected at CTC screening. And for a number of years, our CTC screening volumes were actually fairly robust, but for a number of reasons, we've been fighting an uphill battle ever since, which I think we'll elaborate on a little bit later.
Yeah, it sounds like it's really been quite an effort over the years by you and your team to build up and maintain that program. So what are the high-level findings from your current 20-year analysis?
So in looking at this 20-year history of the program, with this dedicated approach, as I mentioned, we don't treat this as just an imaging test, but a program like breast cancer screening. I think we were able to show that we can achieve excellent results for both cancer prevention and screen detection of cancer. That's really on par with optical colonoscopy, but importantly, we were able to do this in a safer and more cost-effective manner than colonoscopy screening. That's the standard, of course. And I would also add that it's more clinically effective and cost-effective than stool DNA or Cologuard screening, given the fact that it, CTC has the preventive nature and has a similar cost. So we really feel it fits in perfectly as sort of a Goldilocks test for colorectal cancer screening in between the existing optical colonoscopy and stool-based testing.
Yeah, and the results that you share in the article should be helpful as benchmarks now for other practices. So you mentioned in the article that over 99% of the exams were covered by commercial insurance or third-party payers. I know you alluded to this earlier. Could you give us a little more detail about how you achieved that and if that matches what other practices can expect?
Yeah, it's a great question. So as I mentioned, we had this broad local coverage from the very beginning, from day one. But over time, I think what's not well appreciated is that essentially all of the major national private third-party payers and insurance plans have since agreed to cover CTC screening. And I think this has largely been overshadowed by the fact that CMS over this period of time didn't cover CTC screening for Medicare beneficiaries, at least not until January of this year, 2025. And in some ways that I think this is more of a symbolic need to have CMS, but it really only addresses those 65 and older and not the 45 to 65-year-old age group, which is really where I think CTC screening is most relevant and can have the most benefit. So I think others, that want to take a programmatic approach can expect to have broad coverage. And now that also includes Medicare, which is critical.
The number of CT studies decreased substantially during the 20 years, from about 1,600 screening exams in the first year to about 70 at the end. What are some reasons for this decrease?
Yeah, and that's another key finding. In addition to just our clinical results, the volume change over time, I think, is really worth delving into. As I alluded to earlier, we have had repeated headwinds from many different directions, but specifically, there are quite a few factors. First, the gastroenterologist initially put up a bit of a fight, and I would say that continues to some degree to this day, although mainly just from more of the private sector, because national societies like the AGA nominally endorse CTC at least as a secondary option. And even though gastroenterologists don't directly control patient choice of screening, that their blessing, I think, is important to primary care providers. Now, speaking of primary care providers, those are the folks in the trenches that are largely responsible for colorectal cancer screening. And unfortunately, despite our efforts, they remain largely unaware of the benefits of CTC. And this lack of Medicare coverage also gave it perhaps an investigational feel, even though it clearly was beyond that. We also have a lot of PCP turnover, so it's a constant struggle locally to educate our new providers that are coming from places where CTC is generally not offered as a screening test. So those are a couple of things. We've always been fighting against the national picture as well, where CTC screening really is yet to take off. And in the paper, we include one year, 2017, where there's available data. There are actually only about 2,500 or so screening CTC exams performed nationally. And of course, our program alone represents a big chunk of that. So we're always fighting that national picture as well. And then there are the overlapping issues that have come and gone over time. Those include radiation dose concerns, extracolonic findings, flat lesions. All of these are more of a smoke screen, I would say, and not really legitimate reasons when you examine them more closely, but they can certainly be put up as a reason not to do CTC. We also had to fight the emergence of Cologuard or spool DNA testing, which, quite frankly, it's easier for primary care providers to simply check a box, even though it lacks prevention by and large. It's still quite easy for them to at least say they've screened the patient. And then there's also the continued willingness of insurers to pay for the high costs of colonoscopy screening, which obviously remains the dominant modality for screening in the U.S. And I think if insurers start to realize they can get more for less through a safer, less costly approach like CTC, maybe we'll see that turn around as well. And then finally, I would say we as radiologists really represent another important barrier. And by that, I mean, as we have ever increasing volumes of studies to read, adding CTC to one's practice might not be a very appealing addition, as it takes longer to read these exams and carries more baggage than just reading a typical CT, for example. So in that sense, we might be our own worst enemy if we're not willing to offer this to our patients.
For practices wishing to develop their own CTC programs, what recommendations do you have to address these issues?
Yeah, that's another good question. I mean, I think for all the reasons I've talked about above, I think radiologists really need to approach CTC screening, more as a program again, not as a standalone test to be read, and treat it more like, say, breast cancer screening as a program, with like an end-to-end organization for things like scheduling, bowel preparation, scanning, interpretation, reporting. All of these things are critical. And, as I mentioned, we've had a program coordinator to help manage all this from the beginning. Perhaps the ACR could help provide some support and guidance for practices as well. But I think even for those that are unwilling or unable to read the studies, but perhaps can provide quality scanning, there are emerging groups that can offload this task as a service, but still allow practices to keep their technical revenue. So that could be a potential partial solution. And then I think to increase efficiency going forward, I think next generation add computer-aided detection using more deep learning AI approaches will likely be good enough for first read approach, which would really slash reading times. I know this is once considered kind of anathema to include, first read CAD, but that could be a reality as these tools are probably going to get to the human level, if not better, for initial detection. And that would just allow the radiologist to quickly go through and determine which hits represent real polyps. So I think you could see reading times cut, to a fraction of current fly-through times.
Lastly, you mentioned in the discussion that CTC can also be used for opportunistic imaging. including to look for osteoporosis and conditions affecting a range of organs. Can you describe this future outlook in terms of how CTC can be used for wider health screening?
Yeah, absolutely. Actually, this is the part that excites me the most and has really been a major focus for me, and this goes well beyond CTC, but to all of CT in general. But I think the opportunistic CT screening revolution is just getting started. And screening for things like colorectal cancer, lung cancer fit in perfectly with this approach. And I think, as all radiologists are by now aware, body CT scans contain very rich cardiometabolic health information, and that using these explainable AI algorithms, we can now efficiently and objectively assess these. So I think we can basically provide relevant information relating to things like osteoporosis and fracture risk, cardiovascular disease and risk, sarcopenia, hepatic steatosis, metabolic syndrome, diabetes, and so on. And without going into too much detail here, we now have composite models that incorporate all these measures of muscle, fat, bone, vascular calcium, liver, and other organs. And these models outperform the best clinical predictive models for quite a few things that that are quite relevant. So this all comes free essentially with every CT scan. So I think to say that this is a virtual physical exam is really an understatement. I think this opportunistic approach, which again applies to all body CT, regardless of the clinical indication, could become actually an intended cardiometabolic evaluation when you combine it with colorectal or lung cancer screening using CT. So in essence, I think this would greatly enhance the overall value of the study, and this is at no additional patient exposure or patient time. And, you could even argue that it could replace standalone things like DEXA, coronary calcium scoring, liver ultrasound for steatosis, lab work for cardiovascular disease, physical exam, and really represent an initial comprehensive health screen. And that's really looking, ahead at the big picture. But I think the potential is there, and we're building on that.
Dr. Pickhardt, thanks so much for joining us.
Thanks. I appreciate it.